All right, welcome. I wanted to spend a little bit of time today talking about what we call it UOA, the lift protocol. The lift protocol is one of the most key concepts of vertical control in all of our fixed and aligner cases. So I want to give you a quick run through that. Like anything though, we want to make sure that we start on the right path. So I do want to give a little bit of background on why this is so important. If we think about the progression of orthodontics, orthodontists solve problems. I mean, we all have this ability to figure things out. I mean, it's why our profession does what we do. We can grab a tool and somehow find a way to solve a problem. If we go all the way back to the start, we looked at the beginning of orthodontics, the inception back with Dr. Engel. He looked at just alignment, right? And then, we moved into this progression of figuring out that the transverse was important. And then we got finally to sagittal. So between alignment, transverse, and sagittal, orthodontics can solve most problems. When we look at where this concept started back in like the 1900s, we had the E-arch, right? The E-arch with Dr. Engel was essentially a wire that he would ligate teeth to and just use traction forces to pull these teeth in. Eventually got a little bit better. He said that wasn't enough control, so he came up with the first standard edgewise system, but it was very labor intensive. So then, we end up with a pre-adjusted appliance. Larry Andrews did all his work and said, look, let's try to develop something that allows us to get from point A to point B without working so hard. Now we have these amazing conceptual braces that have, everything worked out. First, second, third order. They can both be twins. They can be PSL. They could be aligners. Either way, we've got this ability to take care of alignment. So now let's move on to the next hurdle. The next hurdle was understanding that the transverse development or the transverse dimension was one of the most crucial dimensions in treating malocclusions. We began seeing that expansion and development allowed us to treat complex problems. We were, as a profession, taking a lot of teeth in the first generation of orthodontists. So then the progressives in the 70s began to develop things like palatal expansion. Dr. Andrew Haas came up with the Haas expander. People cleaned it up and came up with the high-res expander. And then people like Dr. Damon started pioneering expansive-based dental alveolar systems like the Damon system and allowing us to do dental alveolar expansion, creating a nice, beautiful arch form. Now we have wonderful appliances that they can really solve a lot of problems in the transverse. And we're even going backwards now and using TAD-based expanders to truly gain as much of that transverse as possible. Again, this is a history lesson, not necessarily saying what's right and what's wrong. So we move back into the other dimension, and now we have this AP problem, right? We can solve alignment, we can solve transverse. So how do we take care of one of the most fundamental problems in orthodontics, which is overjet and underbites, right? And that was really done with things like headgear, chin cups. We were trying to control the growth of one or two of the bones. We even started looking at how the teeth are impacted and using things like functional appliances like removable twin blocks, and eventually using elastics in our fixed appliances to control the space as the transverse developed, and also to shift occlusal planes and basically take care of some of the sagittal. We've moved to functional appliances like Mars and Herbst. And even now in our aligner therapies, we have a whole slew of combinations where we have, a case like this, where we're using elastics and a functional and also some sort of like conceptual motion appliance. The problem is that vertical was always an issue. If you look back in the history books, we had these banded springs that would try to move the molars apart. Dr. Graber pioneered things like magnets that were embedded into these bite plates to try to force the molars apart. Dr. Meow pioneered the Meow arch wire for open bites. I mean, if any of you guys have ever bent one of these, it's insane to do, but the idea was to create this intrusive force with flexibility as long as they were wearing the anterior rubber bands. Now, if any patient didn't wear the rubber bands, you would create even a worse open bite. But now we've moved more into this concept of TAD-based intrusion, which we're going to cover today. Something as complex as a Meow arch wire can now be handled with some simple screws. But yet again, we complicate things, and now we're moving back to this idea of making things sometimes more complicated than they need to be. So let's go ahead and look at what I consider a blind spot in modern orthodontics. I do believe that the vertical is a blind spot. And the reason why is if we look at all of the pioneers, Dr. Profit said vertical discrepancies are amongst the most challenging malocclusions to treat. Larry Wolford, long face open bite cases require surgical management because orthodontists can't typically take care of the vertical problems. We look at Dr. Van Arsdal. Vertical control is the central piece of aesthetics that it's so underemphasized due to biomechanical limits. And then Dr. Sarver, who is one of my biggest mentors about aesthetics, just talks about we need to treat the face and not the occlusion. So when we look at this, the vertical component brings up everything. And if you summarize it, the pioneers showed that the vertical dimension drives mandibular rotation. It definitely affects facial balance and growth pattern, yet still is one of the most difficult dimensions to control. So when you look at the definition of blind spot, it's a weakness, ignorance, or area of prejudice about a certain subject or topic. I do believe that in orthodontics, we do look at the vertical as a blind spot. We have all this argument on transverse. What's considered to be proper? Is it skeletal? Is it dental? Is it dental alveolar? Orthodontists go to war over transverse, yet they never ever talk about the vertical. And this is profession-wide. So I think seeing the vertical matters more than ever because vertical excess is not simply a bite problem. It's a facial growth pattern with dental, functional, and systemic consequences. Everything from how we look to how we breathe. You cannot finish aesthetics, occlusion, or airway predictably without understanding how to not only control the vertical, but reverse it and correct the vertical problems. So we really need, as a profession and as orthodontists, to start seeing. We want to understand and experience what it is that we need to do. So let's kind of summarize this. What's the problem that we see every day that we might ignore? When somebody comes in and they have a vertical problem, we see over-eruption of maxillary posterior teeth. We see this auto-rotation, which is down and back. And then we see sometimes posterior anterior gummy smiles, poor facial aesthetics. Let's kind of uncover these each one at a time. So if we go ahead and we look at maxillary posterior over-eruption, this is the root cause of it. When we have some reason, whether it's genetic, environmental, breathing, mouth breathing, it doesn't matter. Whenever the forces of occlusion are holding the teeth together, we get vertical eruption of the molars. Now, predominantly, it's in the upper molar that we see this vertical. And when we see it, we can get a posterior gummy smile, premature occlusion, tooth wear, and sometimes we could see an anterior open bite. But let's move down the road. What happens when we get a vertical change? Well, the subsequent movements are that the mandible starts to rotate down and back in a clockwise fashion. And we all know that when we start seeing a mandible move clockwise, it's not good. We get increased vertical dimension, increased lower face height, which is unesthetic, mandibular retrusion, and we also get lip incompetence. So when we see these increased lower face heights, and again, it's due to lots of multifactorial reasons, you get all the effects of maxillary posterior eruption, clockwise rotation, but now we have this issue where we have mandibular retrusion and incompetent lips, and now we have this breathing issue that unfortunately gets worse and then sustains itself, almost like a dog chasing its tail. So it gets worse as we grow. And then, the epitome of what orthodontists look at clinically as being the most significant problem with vertical dimension is an anterior open bite, right? We all know that there's way more to it, but the occlusion shows that we end up with clinical open bite or extensive gum show. So really, when you break this down, the vertical problem doesn't resolve themselves. They actually compound as we watch a patient grow and we see that they're vertical, and then we layer our treatment mechanics on it, which most likely and historically exacerbate the vertical problem through molar eruption, we make this problem worse. And I think today is a very different concept. We can either be like this lady on the left or this guy on the right. Lady on the left just closes their eyes. The guy on the right is like, wow, I can't believe I'm seeing this. The limitations are not biomechanical anymore. It's fear and lack of exposure and dogma. We don't miss vertical problems. We actually see them and we choose not to act. And I've had this conversation with many of my colleagues where, they start kind of talking about transverse and I go, let's talk about vertical. And it's like a blank stare, right? So we have to figure out how to solve these problems. So the cool part is we have a shift from dental camouflage to skeletal control. We don't have to rely on invasive surgery. We don't have to rely on passive acceptance, meaning this is the best I can do. I'm sorry. And we also don't have to look at active ignorance, which means that I see your problem, but I'm not even going to bring it up because I really don't want to or don't know how to treat it. I think that temporary anchor devices allow for direct skeletal force applications, and they are very easy to use using the right protocol. So why do we attack the posterior maxilla? Well, there's a reason, because it's the primary driver of vertical excess. When the molars erupt, we have a mandibular rotation, and then we have this auto rotation moving forward, which means predictable intrusion of the molars results in positive dental and facial changes. So once you control the posterior maxilla and the teeth included, everything downstream gets much easier, right? This complicated open bite, once you solve the vertical problem, becomes some misaligned teeth. That's it. So what I'm going to do is introduce what I term the lift protocol. Now, why did I call it lift protocol? Because it's fun. I always talk to patients about, I'm lifting the molars up. I'll look at the parent and I'll grab their handbag and I'll lift it off the floor with two handles. What it stands for is load-induced force technique. In other words, we're going to induce a load on these molars to intrude them. And here's the technique. So if we look at a cross section, we're going to see that we have the molars. This is basically the first molar that we're looking at. We see the mucogingival line. The first thing we're going to do is we're going to place two 8mm TADs. I use Vector Test from Ormco. I like it. It's titanium. It works well for me. But we're going to use two 8mm Vector TADs placed on the buccal just at or below the mucogingival line, right between the first and the second molar. The second set of TADs we're going to place is two 8mm TADs on the palatal. Now we're going to place them between the first and the second molar, roughly halfway down the alveolar ridge between the palate and the margin of the tooth. The third thing we're going to do is we're going to bond buttons on the lingual of the first molar and the second molar. And if we already have brackets on the first molar and second molar, we're just going to use the wire. If it's an aligner case, we would bond buttons there and then have cutouts. And then the last thing we're going to do is activate each TAD with 60 grams of force. This just happens to be one link of active generation 2 power chain closed. And if you look at this from the two other sides, from the buccal, you can see where we're placing that TAD. And then from the palatal, you can see where we're placing that TAD and how we're tying it. Now look at the resultant forces. If you look at the top, the forces are moving out, but the resultant force is going to be straight through the tooth. And if you look from the left, the resultant force is up, whereas the resultant force between these converging forces is actually through the TAD and vertical. So you get pure intrusion of these teeth. Now we're going to go ahead and show this clinically, and I'm going to walk you through this. So, forgive some of the color. I had to use a special light and it's hard to film this, but we're going to go through the process. And this is a very simple protocol. The patient's rinsed with chlorhexidine. They already know what's up, and we've numbed them with articaine with a little bit of an infiltration. So the first TAD that goes in is the maxillary right posterior, and we're going to place it right at the mucogingival line. As we're turning this, we're keeping our palm very steady, and we're making sure that it's driving in like we would drive in a screw. It's also important to know that when you release this, especially what I love about the Vector Test system is the handle is very heavy, but you'll click it back and release the handle so that you can wiggle off the driver. If you use the handle to wiggle off the driver, sometimes you flex the head too much and then you cause the cortical plate to fracture near the screw, and that's one of the reasons it fails. So we're going to go to the opposite side because I like doing the same thing twice. We're going to go between the 7 and the 6 at the mucogingival line, and we're going to go ahead and drive an 8mm TAD into that so that it's right at the mucogingival line. You can see how easy that is, okay? Now, the third TAD that goes in is in the palate. Now, I use the contra-angle head because it just makes it so easy to drive it in perpendicular to the bone. But you can see I'm putting pressure on the head, turning this, it goes right in. So we get about 4 millimeters to 5 millimeters of bite in the TAD, and then the same thing on the maxillary left side. This is going to drive in between the 7 and the 6 at a right angle to the alveolar process. And you can see now in a short period of time, which clinically it takes maybe about 4 to 5 minutes, we're going to place all the TADs. So now we're going to go ahead and start activating these. And you can see that we just basically use one link of active C chain. So for that side, it's going to be 5 links, 1 on the button, 1 miss, 1 TAD, 1 miss, and 1 on the button. It's a little bit clearer on this left side. Again, this is generation 2 closed link power chain, goes around the TAD. I like the generation 2 because it's thin and I've measured all the forces. It gives me the most consistent 60 gram force per 1 link of activation. Now from the buckle, I'm going to go from the tad around the wire and then go back up to the tad. It's very important that you make sure that you're in a fairly large wire by the time you do this. You don't want to start with an 014 because all it's going to do is bend the wire and create a gable problem. So if I have a patient who's really, really excited about getting tads, I'll start tying at the 018, but I won't tie it very heavy. And I'll wait till I get to a rectangular tie wire to tie that. So if we look at our patient that I was using before, this is a girl who came in and her mom was a hygienist, and she was told by another orthodontist that she would just have to wait until she was older to have jaw surgery. And I told the mom that no, we're going to go ahead and use some tads, and we're going to use our lift protocol to lift up those first molars. And she was on board. So if we look at how this works, this is only about 4 to 5 months into treatment. You can see that those molars are already off the occlusal table. The only thing holding the bite up right now are those deciduous second molars, which we had extracted, and her bite closed right down. The braces were there to straighten the teeth. Again, I use an Ultima full expression system, but whatever system would get you where you need to go, you know how to do that. The idea of the lift protocol is that I'm lifting these molars out of occlusion to auto-rotate the mandible forward and close the bite without erupting anterior teeth. So that you can see in a short period of 13 months, we were able to treat this beautiful growing girl, decrease her lower face height, improve her airway, and restore a normal facial growth pattern. We all know that if we would have let this go, this would have gotten worse and not better. And if we would have tried to use vertical elastics or class 2s, it would have again exacerbated the problem. So hopefully you find this to be very, very helpful. I want everyone to just take this simple protocol, know that it's very, very easy to use, and really start treating the dimension that I would say most orthodontists ignore. All right? Take care, good luck, and if you like this content, feel free to follow us and make sure that you check out all of the content that we're putting out. This only continues to get good and grow with engagement. So if you like this, forward it to your friends, and please let us know if there's anything else you want to learn. Take care. Bye-bye.